At this time, I would like to introduce our first speaker, Dr. Rajitha Bavaraju, who is the Deputy Director of the Global TB Institute at Rutgers University of New Jersey. She has worked in the field of TB for over 20 years on the state, national, and international levels, and has served as an author for several papers and resources on TB and stigma, as well as patient-centered care. Thank you, Rajitha. I will turn it over to you.
Thank you so much, Shweta, and for that introduction. I am certainly not an expert on this topic. I think there's a lot of you out there in the field who have many examples on how stigma has affected the care of the persons you work with. I hope that there's some TB survivors who've also called in. What I like about this is that I'll be sort of sharing some background and data, and then really at the end you're going to hear firsthand from someone I consider a friend, Khair Abdi, who will actually talk firsthand on this issue. Let me figure out how to do this here. So before we begin, today is Valentine's Day. So I wanted to start actually with a couple of graphics that I found through the Stop TB partnership, which are kind of a nice way if you want to go into your social media platform. I'm having a little issue here with trying to forward. Let me see. Okay, so there's a couple of great graphics that are out there on TB and stigma, and today is the perfect day to kind of get those up and out there. So if you're willing to do so, you can go ahead and get onto your Twitter or your Facebook or Instagram or wherever it is that you do your social media and sort of post these things out there a little bit differently than what we normally see out there. So to begin, I just wanted to go through my objectives. So there's a large body of literature on stigma, not just in TB, but in many other fields. And so I want to just really start with a basic overview. So for time reasons, I'm going to really try to keep this presentation, get us the literature, and then try to keep it as practical as possible. So the objectives are to define stigma in the context of tuberculosis prevention and care, to describe how stigma affects persons with tuberculosis, and to apply interventions in the healthcare setting and community to reduce stigma. So stigma is not natural. It's enabled and it's embedded. So from the 2018 TB stigma measurement guidance, which was a work of a number of individuals plus or really sort of spearheaded by WHO, KNCV, and the Challenge TB group, stigma can be described as a dynamic process of evaluation that significantly discredits an individual in the eyes of others. With particular cultures or settings, certain attributes are denied by others, or they may be discreditable or unworthy. So when stigma is acted upon, discrimination may result. And this last part is really, really important when it comes to health-seeking behaviors and adherence-related behaviors, which we're going to explore a bit later. So there are various types of stigma. The category names are not important. I'll go through them, but what we should note is that stigma can come from the community or it can be internal. It can be a construct that one assumes will occur based on a past experience or based on external circumstances. So public stigma, as it sounds, is something that's generally held by the community or by the general public. Anticipated stigma is the worry that someone might be devalued, which may delay people in returning for care or even showing up for care, and it could impact adherence. So whether or not stigma is actually occurring, anticipated stigma may interfere with care behaviors or actually, as I said, returning for treatment or health seeking. Secondary stigma refers to the idea that caregivers, friends, family members, or health workers may experience negative attitudes or rejection because of their association with a person with tuberculosis. Furthermore, this may dictate their behavior or beliefs, regardless of whether the stigmatizing attitudes or reactions actually occur. And we see this a lot in many settings abroad outside of the United States where the TB rates are much higher and people are working in these very high burden settings, working extremely hard, and oftentimes there's stigma just for healthcare workers. And some of these healthcare workers actually contract TB. And so it makes it really challenging for them because they're sort of facing other types of stigma as well. Internalized or self-stigma captures the idea that individuals may come to endorse negative stereotypes, and therefore they might behave or think according to these false portrayals and negative messages. And then the last two terms, so enacted or experienced stigma is the range of stigmatizing behaviors, messages, and effects that are either directly experienced by the person with TB or their families, or that drive others to acts of discrimination, rejection, or isolation. And then finally, structural stigma describes laws or policies and the institutional architecture that may be stigmatizing or alternatively protective against stigma. This includes societal level conditions, cultural norms, institutional practices that may constrain opportunities or resources, and the well-being of these stigmatized populations. So again, what's important about these concepts is not so much what they are called, but that stigma can actually be measured in different ways, and these really should be considered, these measurements should be considered in order to better the TB diagnosis and treatment experience for both the patient as well as the healthcare worker or the clinic or health department, wherever it is that the patient is being seen. So again, from the stigma measurement guidance from 2018 that I mentioned earlier, this great diagram depicts all of the stressors a patient might primarily have along their journey towards diagnosis, treatment, and recovery. And a lot of this can also be based on the community that they live in, if they're in a rural or urban setting, what the rates of TB are in their community, so how quickly they get to treatment or to recognition that they need treatment could potentially be affected by kind of where they come from. And as you can see, stigma really affects the journey of health-seeking behavior really early on. It can represent undercounted reports of TB in the community and contact tracing for a person at high risk of exposure. So I thought it was a really nice diagram. Additionally, but not surprisingly, stigma and depression actually go hand in hand. So these both affect one's ability to work, to socialize. They may cause a lack of willingness to adhere to treatment. The model shown here on this screen is from Annika Sweetland and colleagues, who's done a lot of work in mental health and TB. And stigma is one of the mediating factors in depression. We often think about depression resulting from TB as a result of a medication they might be taking, like cycloserine, for example. But really, there is sort of stigma that can also lead to this idea of illness-seeking behaviors, and follow-up. And these mediating factors, depression in this case, can lead to treatment failure, loss of follow-up, and relapse. And this can create, of course, additional drug resistance, a lack of cure, and then, of course, as a result, additional transmission of TB in the community. So Sweetland and her colleagues and some of the groups, the union has a mental health and TB working group. They're really kind of looking at some of these factors related to the diagnosis of TB and not just, the treatment factors related to the medications. So as we continue kind of through the literature, and as we've shown thus far, the stress of stigma has multiple effects. So stress can weaken the immune system. Additionally, the negative connotation of TB can create shame, guilt, discrimination, and isolation. And finally, stigma can lead to delays in health-seeking behaviors. So Balasubramaniam and colleagues showed this last concept was very specific to women in a study in South India. And these are just a smattering of some of the studies that are out there on stigma related to TB. There's actually quite a few that are out there that have looked at this area and topic. So as we've seen from these various models in the literature, again, stigma can lead to social isolation, depression, unemployment, negative labels on patients, delays in health-seeking behaviors or seeking care in informal or alternative health settings, lack of adherence and acceptability for treatment for both active TB disease as well as latent TB infection, transmission to others through things such as poor personal protection as well as not naming contacts. And finally, it can also lead to the lack of accurate research data and participation in TB-related research. And I'll cover these all more in a little bit of detail. But the effects of stigma are not just on the individual with TB, but on the community and healthcare workers as a whole. So TB really does affect the community and healthcare personnel. So an example of these compounding effects has been shown by Nyasulu and colleagues in Malawi. So lack of appropriate education and TB transmission and causation in conjunction with these external perceptions of cause as being based on things like sin or witchcraft or associated with things like HIV can really lead to barriers in care. The misinformation about the causes of TB are not just prevalent in this setting, but in settings throughout the world. So it's really important when you're working within a community, regardless of where that community is, to find out what people know about TB. How is it transmitted? How is it stopped? What are infection control mechanisms? So these are good things to test for. And I think there's been a lot of good work done in the field on knowledge, attitudes, and beliefs about TB, which are still important when you're not just interacting with persons with tuberculosis, but also their caregivers, health departments, health settings, and the development of any kind of campaign materials or educational materials. These knowledge, attitudes, and beliefs in terms of measurement are really, really key. So without interventions and action strategies as intermediaries, adherence to treatment and follow-up to care and prevention of transmission of TB can run rampant in the patient's treatment. So in the model shown here, Chuang and colleagues have gone a step further, and they actually show that a positive sort of system-wise intervention course, such as social support, access to health care, and positive resilience for the patient who feels stigma can really have positive consequences on care, including adherence and completion of treatment and prevention of the treatment of TB to loved ones. So we've talked about sort of the larger consequences of stigma, but what about the true manifestations in everyday life? So, going from sort of the theoretical now to really talk about the practical. Stigma affects the way in which persons with TB are referred to. Stigma can affect whether one engages in infection prevention interventions or not, such as mask use. There's an effect on the use of government services. There can be workplace discrimination in the form of isolation or discontinuance of someone's employment. And the social norms of the way we see persons with tuberculosis or those affected by it can be negative. And I'll expand on this a bit further in the following slides. So various studies globally have shown that there are false and negative associations with persons with TB and persons affected by TB. So we talked a little bit about how there's a lot of these studies out there that have looked at knowledge, attitudes, and beliefs in various settings, which are very, very important to continue the work that we're doing to understand the groups of people that we're interacting with. So these associations can include things like poverty, HIV infection, or other illnesses, poor hygiene, heredity, which can lead to marriage prospects in some communities, bewitchment. TB can be looked at as a death sentence or something that can't be cured. It can also be associated with other health behaviors, including excess smoking and alcohol use. I'm sure a number of us who work in the field, when we talk about, oh, we work in TB, people say, oh, isn't that caused by smoking or isn't that caused by heavy drinking? There's sort of these misconceptions out there about how TB is caused, and so it's our job as providers or people who are survivors of TB to sort of send out those positive messages and factual information that's out there. So having provided this background, I'll now talk a little bit about what we can do as a community about reducing stigma and the effects of stigma. So related to the slide on effects, we can use patient-centered language, explain infection prevention methods to a patient. We can provide peer support. We can note that TB may not be that patient's only concern. We want to work with the media for positive media messages and health education messages. It's really important to disassociate immigration status with healthcare. We need to create confidential and discrete clinic and community-based treatment. We need to associate contact tracing with education and make it judgment-free. And finally, we need to measure stigma pre- and post-interventions. And as we do some of these things as individuals, larger interventions are needed, and we should include patients and their communities in their design. So I'm going to expand on these a bit further. So language. It's a challenge when we talk amongst ourselves as healthcare workers versus with a patient or about persons with TB in the community. So if you go into a congregate setting and you have to do an educational session about an exposure in an environment, we are always challenged in terms of how we talk about people, respecting confidentiality and respecting the humanity of the people that are involved in this process. So we really do need to make a conscious effort to use patient-centered language. There have been quite a number of documents and articles addressing this issue in the last few years. One of the things I've seen in the provision of guidance on on submitting abstracts and articles for conferences and for peer-reviewed publications is this idea of using patient-centered language and non-stigmatizing language. So I think we're really making, a positive effort. I think the TB field has been a bit slow in this area, but I'm glad that we're now finally catching up with a lot of really great advocacy work from communities themselves. So some of the examples of language include words like defaulter, TB suspect, case, compliance, TB control. And alternatives for these terms are actually shown on this slide. So instead of saying defaulter, you say a person who might be lost to follow-up. Instead of using the word suspect, you might say a person with presumed TB or a person to be evaluated for TB, and so on and so forth. From my experience, persons who've been affected by TB, and Kyer can talk about this a bit later when you hear from him, do have varying opinions about how they want to be referred to and about these terms. And so this is an ongoing discussion that we need to engage in and have further in our communities and amongst our colleagues. So it's not easy, it's not a cookbook in terms of how to use this terminology, but it's definitely something that we need to be conscious of. Regarding health-seeking behavior, how persons are exposed to TB or notified of the exposure should be considered along with the patient. If it's done by a healthcare worker as a third party, confidentiality, of course, has to be maintained. Patients should be given a choice of how their contacts are informed, if possible, if that's a luxury that you have in your program. And when following up in the field, we really need to be discreet, aiming to not appear like we're a legal government representative looking for someone who's committed a crime. We must name TB clinics cautiously so that people are not afraid of entering them for fear of being discovered. And finally, active case finding, as we mentioned earlier, is something that really needs to be done with discretion. So depending on who you have doing your work in the field, it's a nurse, it's a community health worker, it's a public health representative, as we call them in our clinic here, discretion, confidentiality, respecting how the patient wants their contacts to be informed is very, very key. And that's a decision you need to be making with that person. So I heard a person who once had TB once explain, and this is a person who's in isolation, explain that she never saw the faces of her physician or her nurses in the hospital because they were constantly wearing respirators. So when they entered the room, the respirators were on. And the use of the N95 respirator was actually never explained to the patient who was in isolation. And had the patient known why people had these respirators on, they actually would have actually been okay with it. But again, because they had never been told, they felt sort of like the stigma was actually worse than what they'd already been feeling. So it's really important for health workers to take care in explaining to patients about the use of infection prevention, that we have to use them and explain why they're being done. Additionally, if there's TB in the community or in a congregate setting, education needs to be done to dispel myths about the spread of TB. And finally, one needs to be super aware of nonverbal cues. So thinking about moving away from a patient or not touching a patient, these are little things that can make a huge, huge difference in the care of the person that you're dealing with. And this is not just in TB. When we think about our visits with our doctor's offices or wherever it might be, how the provider looks at us, the healthcare worker, the nurse, whoever it might be, looks at us and treats us just through simple nonverbal cues can make a huge difference in the way we feel, how comfortable we are, and whether we're going to reveal information to that individual about our health history. So that thing is certainly important to think about. Support for both patients and their families is needed beyond the standard medical care, and this can include support groups or counseling based on a formal or informal assessment, incentives if appropriate, because remember, not all patients find incentives dignifying, so don't assume your patient wants an incentive. Removing airborne infection isolation precautions as soon as possible. Treatment outside of the hospital is really, really important in the clinic setting as much as you can do, and if it's convenient for both you and your patient. And finally, if you can provide regimens that are customized for the person that's taking them. And again, a lot of this is the luxury of the program that you're working in, whether you can do some of these things or not. Additionally, when we think about culture, if a healthcare worker needs to enter a community to provide directly observed therapy or to do a contact investigation or contact tracing, you might need permission to go into that community, and that's something that we need to respect. We also need to be aware of the association of government agencies. Persons who have been persecuted can often view public health authorities as people who are untrustworthy. So we need to really be careful of that. Advocacy resources exist, but I don't know, in my recent view of some of the advocacy resources out there, there's some that are out there that are scary, and they're there to embolden for funding or calls for action for TB, and that's great. But when it comes to a person needing support for their healthcare or their TB, we need to have more effort to make positive patient support materials and resources. While we need to recognize the negativities of TB to call for more action, for patients, I think some of the more recent messages really need to change, and I know there's a lot of work being done in this area. There needs to be more positive survivor stories in educational resources and in the media. Interventions like preventive therapy need to be maintained as a positive thing, so those individuals in some areas who have HIV and there's an IPT protocol, again, IPT needs to be positive as opposed to something negative or an association with something. Interventions like adherence needs to be noted as positive, whereas something that you're going to be punished for if you don't deal with. And finally, when we screen patients for TB, questions need to be framed as non-invasive. I've seen examples of turning TB infection and refugee screening as a way to create anti-migrant sentiment, for example. So we really need to be careful about the messages that we're sending out there and also the questions that we're asking. So, for example, if you're asking a screening question, we need to ask about HIV status, for example. We need to explain to the patient why we're asking them about their HIV status, especially if it's going to come in at left field from them. And so those things are important in terms of building rapport and trust with that person that you're treating and potentially going to be working with for a really, really long time. TB services need to be disassociated with immigration status. Persons need to be assured that care will be provided regardless of their legal status, and this includes the identification of contacts in congregate settings. There also needs to be continuity of care for patients who cross borders legally or without documentation. And this is oftentimes for economic reasons or family reasons or because they're experiencing trauma where they are coming from. And so that continuity of care is where I think all of you in our community, I think, really do a great job at using ways of making it so that this is a usual practice for them so that we can make sure that these persons get better regardless of sort of where they're staying, whether they're in our country or in other countries. Migrants in particular, should not be ashamed to ask for some accommodation of care as well as record sharing between healthcare providers so that, obviously they can get better and protect the people that they care about. And then we talked a little bit about contact tracing, so I'm going to get a little bit more about it on here. So contact tracing or contact investigation, how this is framed can really, really help to reduce stigma. So patients should not feel blame for the infection of others. They should be reassured about confidentiality. And finally, when contact tracing is done, questions about whom a patient has spent prolonged and frequent time with can extend beyond their traditional household. And we need to be really aware that a patient may be reluctant to reveal certain relationships, particularly if they're out of the norm or considered unacceptable in certain communities. So it's really important to stay persistent, but not appear invasive when you're trying to find out from people who they've spent time with. They're already feeling perhaps a little bit of guilt about this infectious process, and now to say to them, oh, listen, I want to know about everybody that you've spent time with. So we just need to have a little bit of patience. And contact investigation and interviewing is a whole other skill, which we don't have time to talk about here, but it's really an art and a skill and not easy to do without, I think, some good models and good training. And finally, I mentioned this briefly, this idea of doing a better job of assessing both stigma for individual patients as well as part of research. Physicians and nurses should be aware of stigma. Stigma is something that healthcare workers often might feel as well and should be considered. There needs to be frequent surveys of clinical services and settings, which include how people feel about their services and barriers. I don't know how many of you in your settings, again, if you're based in a hospital-based clinic, if you're based in another place, how many of you have patient satisfaction surveys? Oftentimes they're seen as sort of this black box of data that's out there, but I think it's really, really important to ask people, either in person or confidentially, however might work for you, about how they feel when they walk into this clinic. Is the name of the clinic stigmatizing to them? Is the front door where they're going into stigmatizing? How do they feel when they walk in? Is the clinic being shared by other settings? And the worker who is the receptionist in one area looks at them differently because that person works for another program whereas someone else is working in the TB clinic. So it's really important to ask people how they feel. It's important to ask people how they want to be addressed. Is the name that's written on their insurance card or on their birth certificate the name that they want to be referred to by? So these are all things that we need to ask about in a non-judgmental manner to assist with measuring stigma. And this is just on the clinic level. It's something that we need to be aware of. With regards to research, generally recruitment for TB-related research can be challenging because of stigma, especially when you're trying to collect qualitative level of data. It takes more time. You're asking people perhaps to reveal things that they don't readily want to reveal. But we really need to persist to include more people affected by TB in research. Additionally, research should employ mixed methods. So we need to include the assessment of policy documents. We need to look at discrimination and stigmatizing language in these policy documents, particularly around things like employment or housing. Those things are really, really key, and this should be part of the research process. The results of TB stigma research need to become part of local, national, and global policy documents that are out there, and not just passive guidelines. So these are also key to look at. So I've kind of taken you on a journey looking again at kind of the theoretical constructs and basis of TB, and then we looked at, I think, some really practical examples. And I know many of you, I know there's a lot of experienced people on this call, and you probably have lots and lots of examples of what you've done to reduce stigma in your settings. So to conclude, stigma really needs to be acknowledged amongst our communities, so patients, families, healthcare personnel, communities. We need to be cautious in these various levels of care and the arenas of care to prevent, recognize, and address stigma for better illness outcomes and the prevention of TB transmission. And finally, stigma reduction is the responsibility of all of us. It's a responsibility of healthcare personnel, facility administrators, the media, and the government. So it's really something that we all sort of need to go together. And we shouldn't be afraid of working with sort of non-traditional partners in dealing with this. I think the TB advocacy community has come a really, really long way in my time in working with TB. And some of the greatest advocates for TB out there are not physicians, they're not nurses, but they've worked really closely with those individuals. And I think we need to do this together. So I think that's something to look forward to. I referenced a lot of literature. If you're interested in looking at some of the references, I'm happy to reach out to me. I'm happy to share them with you. I think there's a lot of good tools, but I would definitely recommend, sorry, I'm trying to get my pen to work here. I'd really recommend this WHO Challenge TB Measurement Stigma document, which I think is really, really helpful in terms of some of the work that we're doing out there. And then there's good literature out there that's just on language in general. So with that, I want to end with a quote here from a great other social media tool that's out there. So it's Valentine's Day, which goes along with the Stop TB Partnership World TB Day theme this year. So can we propose that we end TB together as well as stop stigma? So with that, I'd like to turn the program over to Khair Abdi, who is, I'd like to say as a friend. I had the opportunity to meet him in his home state of North Dakota. Dee Pritchett, who is the program manager there, actually had the foresight to bring him to a meeting, and so I want to thank her for introducing to us and our community. So Khair is an MDR TB survivor. He spent the early part of his 20s working in Somalia as an interpreter and translator, and while studying abroad in Nairobi, Kenya, he started exhibiting symptoms of TB, and he went back to Somalia where he was diagnosed and started treatment. And when he didn't get better, he came back to the United States, where he was diagnosed with MDR TB in 2015. and he completed his treatment after 20 months. And as I said, he now lives in Fargo, North Dakota, which is where I had the great opportunity to meet him. And he got linked up with not only some program managers, but also with some groups through NTCA to do some great advocacy work. So, Care, I'll turn it over to you.
Perfect. Thank you very much, Regina. Before I start, I just want to say that I'm at work right now. I manage a hotel. So I told my staff that I was going to be unavailable for an hour, but, you know, in hospitality, sometimes there are fires that need to be put out. I don't expect that we're going to be interrupted, but if we do, I want to apologize ahead of time. Once again, I want to thank Regina and the rest of the Global TB Institute team for having me. I always enjoy speaking with healthcare providers. I think if you've ever had TB, and especially if you've ever spent any time in isolation, you know, the healthcare providers, the doctors and nurses end up being your friends. They end up being the only people that you have contact with. So I'm always happy to talk with them, share tips, or just share my experience in general. Then I think especially for my case, I was in isolation for 7 months in total, so I think I have a more special place in my heart for you guys. So thank you for having me. When it comes to stigma, I think in my case, the first time that I was diagnosed with TB, I was a senior in high school. So I just finished my senior year at University Park in Worcester, Massachusetts, where I'm from. And I was about to start college. I was staying in my home state, and I applied, and one of the requirements was that I take a TB test to determine if I had TB or not. So went into my doctor, took the test, thought nothing of it, and when the bump came and I came back and he informed me that I had latent TB, that would be my first foray into, I guess, this world, so to speak. And at that time, as you can imagine, being a 19-year-old, the last thing I wanted to tell my friends was that I had, you know, an infectious disease or, you know, be latent or otherwise. In my mind, you know, when I heard the word, you know, infectious disease, you know, usually I think people have one of two reactions, right? I think the first reaction is people think, you know, plague, or they think, you know, SARS, or right now we have the coronavirus happening. So I think people right away just kind of imagine people in hazmat suits and want to get away from you. I think it's, you know, kind of a self-preservation, you know, human nature. And then I think another way people look at it, or that, you know, in my experience, when I had latent TB as a young man, I think that people just associate infectious diseases with, you know, HIV/AIDS or a sexually transmitted disease, and in that way, you know, they just assume that it's something that you brought on yourself by being, you know, not being careful or putting yourself in danger. So, you know, I avoided telling my friends. I started my latent TB treatment, and then I stopped doing it because, in my mind, having latent TB wasn't a huge issue. It certainly wasn't going to kill me from the way it was explained to me. So rather than, you know, show up to the health clinic every day for 6 months, I decided that if it wasn't something that was going to be serious, that, you know, I would just continue my life. After that, I really didn't have, you know, I completely forgot about having TB or anything of that nature, and went about with my life. And the next time that I would experience TB was, like Regina mentioned in my bio, as a college student in Nairobi, Kenya, where I was studying abroad. So I started to experience some of the symptoms, you know, weight loss, heavy sweating, and even though I knew in the back of my mind that it probably was TB, I did not seek treatment because I think, there was that certain sense of, if I admit to having it and if I start treatment, then my life is going to change. I was living in the dorms at that time. I had a pretty active social life, and I didn't want to have to explain to everybody, why I was taking TB meds, or, I didn't want to have to leave school. So I think there's that sense of stigmatization that Regina had mentioned. That, if you start the process, that society is going to see you differently. So I kind of put it off until, I couldn't anymore. And when it was time for me to start treatment, I had the option of either coming back home to the United States, or the second option, which I chose, was to go back to Somalia. So I think subconsciously a part of the reason I did that was I didn't want to come back home and see my family and friends, I think at that time I was at 130 pounds. I didn't want to have to, there was, I think, a level of self-blame that, I had brought this on myself, and I was certainly partying a lot as a college student, going out, drinking, and I was a smoker. So I didn't, and especially I was more afraid of having my mom see me and, think that either they had neglected me somehow, or, I had neglected myself. So I chose to go back to Somalia, where I had previously worked, and started treatment. So in Somalia, I think it's a little different. People are more aware of TB. You usually have somebody in your family who has TB or had TB at some point. But even there's a certain level of stigmatization where people are afraid of, interacting with you because they're so familiar with the disease. So people avoid you. I kept it pretty privately, only my closest friends knew. And, over there's not really a public health infrastructure. So I was going to a private doctor. I was getting all my meds from him. So there was no state infrastructure to, to come test me or to, do direct observed therapy. I was basically taking care of myself, and the greater public didn't know. So I think I was able to get away with, a lot less stigma than I would have had, like in the U.S. So when I came back to the U.S., I came back because I realized I wasn't getting better, first of all. So I came back and came to the state of North Dakota, which I had never lived in before then. I grew up in Massachusetts, went to Africa. So when it was time for me to come back, my mom and family had moved to Fargo. So I came here for the first time ever and ended up, I think, being their first MDR case. So I think the state would have preferred that I'd go back to Massachusetts, where I was from. But anyway, I came back here, and since I knew I was, I had TB, I went to get tested right away and stayed at home. And I think I went to a community health center. So when they did the tests and the tests came back, positive, I had somebody from North Dakota Public Health come to my house. My nurse, Wendy, who I would know for the better part of, I think, the next 2 years. And, she sat me down, explained, that I'd have to be quarantined, tried to tell me a little bit about TB. And at that point, I was, already kind of an expert. But that's when I would start isolation. So the first part was, I was isolated at home, started my the normal, quote-unquote, normal 8-month treatment, and they sent out my cultures, and then that's when they came back that had MDR. And I think at this point they're doing tests at home. I'm living at that time with my mom and my siblings, and my mother did not want anybody else to know that I had TB. So they came, they tested her, they tested the kids, and anybody that had contact with me at that point. So that would have been close family members, my aunt, her kids. She had I think she had about 7 or 8 kids. But I think my mom felt a certain level of intrusion on her life and on our lives. She didn't want other people finding out. So even so, at this point, I don't think a lot of our extended family knew I was back, because she told me, you know, that I should finish my treatment, and then once I did that, then, you know, everybody could find out I was back. I think on a certain level, she felt that the greater community would see, you know, if they heard I had TB, assume that she was a bad mother. Like I said, there's a certain mindset that, you know, the people who get TB are people who are, you know, either drug addicts or, you know, people who live on the fringes of life. So I think she did not want that connection or people to assume that about us. It didn't bother me much, and then that's when I started isolation in the hospital. And I think I have this vivid memory of waking up. I think it was probably like the second or third day, and having 7 doctors kind of standing over me. I think it was a doctor and you know, some of the new residents, and you know, I kind of felt like a guinea pig. So, you know, not surprisingly, I think in a hospital setting, it's always interesting when you have somebody that has, you know, a disease that's not normal or might be rare. So, you know, just that feeling of, you know, having 7 people standing over you wearing masks, I think, you know, kind of irritated me. You know, even though I understand that, you know, it's a learning tool and something that would benefit others if they'd learned about it. It certainly didn't help being isolated from everybody. So when that happens, I think you draw in on yourself. There's a certain sense of, you know, you versus the state, because, you know, they become a part of your life, and for the most part, you know, by force. So nurses coming every morning to do direct observed therapy, going to doctor's appointments, sometimes twice a day, having to be out and about wearing the face masks. And it's kind of jarring when you can imagine how many times have you seen somebody in public with the mask on. I don't think it's pretty common in the U.S., and certainly wasn't in the Midwest where I live now. So I remember sitting, you know, in the doctor's office and everybody in the waiting room staring at me. Even though I could tell they didn't want to, I think there's always that curiosity in the back of your mind where, you know, you see that and you're like, what could this person have? If they're wearing a face mask, you know, it's certainly not good. So having to kind of go through that makes you, I think, even, you know, draw in more on yourself. You feel like a prisoner. So there's that aspect of being removed from society by force, and then having, you know, society kind of shun you when they see you. So I think another part of the stigma that I think was inadvertent was, you know, whenever I'd have my appointments, I think after a while, you know, my doctor and my nurses kind of fell into, you know, a routine where, you know, I'd come in, they weigh me, you know, I'd go and I'd sit, I'd wait for the doctor, he'd come, you know, we'd just talk numbers, you know, we'd look at the chart. So I think after a while, you know, you start to feel devalued, and I don't think that's what they intended, but if there's any way you can, you know, break up the monotony, I think my public health nurse did an amazing job of taking the time to, you know, kind of hang out with me. I knew she was busy, but I think it changed from making me feel like a patient to kind of making me feel like a human being again, where, you know, she'd sit down, watch some TV with me, you know, make some small talk. I used to be kind of messy, so sometimes she'd help me clean. But I think that kind of humanized her and the whole process for me. I mean, obviously, I knew this was something that needed to be done, but I think it's very easy to kind of be looked at, you know, as a patient. And I think that's some of the stuff that, you know, Regina brought up of, you know, how would we want the patients to be seen. So I think, and sometimes when I meet other survivors, I think we always kind of talk about how, you know, you just kind of you feel like a specimen, you feel like you're just being prodded and tested, and, sometimes in fascination when, this is your life that's at stake, and this is what you're living through. I think culture plays a very important part. Like I said, I'm of Somali descent, and even though it's a disease that people know very well, I think there is a sense of, kind of hiding it. People know it's out there. They know that it might be in the community, but nobody wants to really address it. I think certainly I've felt like sometimes, when you're an immigrant and you're new to a country, whenever you have government involvement, I think there's always a paranoia, right? Especially for my mom, who's, certainly not Americanized or still kind of straddles both worlds. I think she was always afraid that, she would get deported, or my aunt didn't want to have state employees come to her house. And I think that's because, they feel like there are going to be repercussions. And even though I explained to her numerous times that, they just want to know who has it or if I passed it on, so, they can stop the spread, make sure everybody's okay. I think that she never really got over that paranoia. So I think, working on an approach to, make the people feel or know that there's, nothing bad will happen is as far-fetched as it sounds. I think there are communities that feel like, they'll be punished for coming forward. Also, I think another thing I noticed was even after I finished my treatment, my mom did not understand why I continued to, be an advocate or, go speak at conferences or, talk to other people or even share that I've had this and, I'm a survivor. And I think in the back of her mind, it was always, this is something that you've gone through. Now it's over, put it behind you, right? There's a certain level of, I think, of shame that communities feel. And I think that's why it's very important for patients who are going through all of this to be able to access or be able to interact with survivors, and if it's possible to interact with other people that are, going through the same thing that they are. When you're, in isolation or going through a disease that many people don't get, it's hard to find literature. I remember kind of poring over the internet and looking for a community. There wasn't one back then. I think I found a blog with Doctors Without Borders, and all the patients were living in Africa or Asia. And that sense of, reading their stories and being like, yes, like I'm experiencing that. You feel like you don't feel, I think, the stigma as much. You feel like, you're part of, the world again. You're part of humanity because there are other people going through this. So I think it's paramount to be able to provide to, patients the ability to be able to interact with people like them. I know right now We Are TB exists, and it's a community of survivors, and through them I've been able to kind of counsel and reach out to people who are going through treatment, and kind of being on the other side of the fence now, I think I'm able to better answer some of their questions. I think you're able to talk people down when you're in isolation or going through something by yourself, quote unquote. I think it's not good for your mental health, and having that person that you can talk to and share the experience, with them, I think is something that, you really can get. So that's those are my experiences with my TB and the stigma that I've experienced. I hope it was helpful. And if you guys have any questions, I'm more than happy to answer.
Carrie, thank you so much for sharing your story. I think it was eye-opening for me when I heard from you, and when I hear from other survivors. Everybody's experiences are a bit different, but I think there's always something that ties people together in terms of things like stigma or the effect of their illness. We actually had a question that came up about costs related to TB, and I'm not sure where the person was contacting us from, but I did explain, TB treatment in this country is free. However, can you talk a little bit about other costs that might occur, job-related or travel? I mean, you're in a fairly large rural state. What other costs are there related other than sort of the treatment-related costs when you have TB?
I think people, TB takes so much of your time, and then obviously my experience was a little different since it was MDR, but it kind of steals years from you. I was I think 21, 22 when I had it. I was in college. I was just finishing up, and you have to put everything on hold. So for a year or 2 years or however long it is, having to kind of give up on your dreams, I think there's definitely a mental cost to that. I think also not being able to work. I have young siblings. We're an immigrant family, so not being able to provide for my mom and younger siblings is definitely something that wore at me. So I think it's not, and then even being not being able to interact with people. I think just imagine any other sickness you might have. That's when you need your family the most. That's when you need your friends the most. And TB kind of takes that from you. So I think those are some of the costs that are not financial.
No, thanks for sharing that. And it sounded like you had a great public health team, public health nurse in particular. I really liked the examples that you shared of how she did things for you just to make you feel human again. I think that's really helpful. Kara, if you don't mind me saying, you're relatively young compared to a lot of individuals who are in the TB community. And I do wonder, you said that you were looking for some support out there, and the first thing you did was you got onto the internet. And you did mention We Are TB. What are some tools that can be out there? If you had sort of the sharks in front of you and Shark Tank, and you could talk about sort of tools or apps or whatever it might be, what kind of things can we do with technology for individuals like you who are younger, and that's the way maybe you get your information? What are some things that I think we could do better or research or look into to support you?
I think being able to, especially because of the isolation aspect, I think having contact with especially non-health providers. I mean, we love our nurses, we love our doctors, but after a while, I think you want to be able to talk with, other people, even if it's, so I didn't have, I wasn't able to even have my family members visit me for 7 months. So so I had, the state provided me, they provided me a tablet. So we used that after I finished isolation. They'd come and do dots in the morning, but then in the afternoon / evening, me and my nurse would correspond through the tablet. I'd take my meds so that way she could see me. So if you're able to provide a tablet to the person and they're able to contact, FaceTime a friend, a family member, another survivor, I think that would go a long way in, making the treatment, easing their treatment. Great.
And again, you mentioned sort of We Are TB. Have you had the opportunity to speak in other venues? I know you talked about doing advocacy work, and you've gotten hooked up with We Are TB. What are some of the things that you've done besides? I know you've done a couple of talks for us, and I know you've spoken at some conferences. What are some of the things that you've been able to do that other people in your situation might be able to do as well?
Yeah, I think we were in DC last year, and we're going to be there again in March, speaking with senators and congressmen, decision makers. So being able to talk with people like that, I think in the U.S. TB is not really on anybody's radar, even though it's the #1 infectious killer in the world. So being able to speak with, because I think nurses and doctors get it, right? But policymakers like that, to be able to tell them, that we're here, we're a segment of the population that for a very long time is underrepresented, not heard. I think TB suffers from kind of being a disease that's kind of in the shadows. And I think certainly having survivors speak out helps. If everybody kind of hides and doesn't want to talk about their experience, then there's no way to kind of change that reality. But policymakers, getting more funding for TB, that's certainly something you guys, right, could use more funding. And just raising awareness, I think is something that, survivors are doing and that, we enjoy doing and we will continue to do.
Great, thank you. So I think we're at the end of the program. Again, Kara, thank you so much for sharing your story. And I also want to thank the TB program in North Dakota, I think, for supporting you and also for bringing you to us, which I think, or to the community as well, so you can share your story with us. And also, I do want to give a shout out to We Are TB. So if you just go to wearetb.com, it's a great there's a great website. You can support people. You can get speakers through that group. It's a really wonderful, wonderful organization. And I know there's some people actually on this webinar today that are from We Are TB. So we really, really appreciate the work that they've done. It's really quite remarkable. Shweta, I'd like to turn it over to you if you have any last-minute housekeeping or anything that you need to cover before we close.
Sure. Thank you, Rajita, and thank you, Kara, for sharing your story. I'm just going to give a few more minutes if you have any questions, the audience. It looks like there isn't any questions, so I'd like to say if you have any follow-up questions, please feel free to email me. That's my email address over there. Sorry, 1 second. And as I mentioned earlier, there will be an evaluation link that will be emailed to all of you. If you could please take a few minutes to complete it for us, that will be very helpful. I also attached a sign-in sheet with the email I sent yesterday, so please complete it only if you're watching it as a group. So I'd like to conclude the webinar. Thank you for all your participation. Thank you very much.